My name is Beth DeYoung, and I am an assistant professor of pharmacy practice in Concordia's School of Pharmacy. I also practice as a psychiatric pharmacist, and today I will be giving you an overview on the medications used to treat mental health disorders. In regard to the learning objectives, I'd like you to be able to identify common antidepressants, anxiolytics, mood stabilizers, and antipsychotics. You should be able to describe common adverse effects associated with psychotropic medications, and finally, explain the potential risks associated with using psychotropic medications in elderly and pediatric patient populations. We'll begin this lecture by discussing the medications used to treat depression. The exact cause of many of our mental health disorders is unknown, and the same is true for depression. We do not know exactly what causes depression, but there are several different theories, and in reality, the cause is likely multifactorial, where we have multiple different things contributing to cause depression. There is some thought that there may be dysregulation with the hypothalamic pituitary adrenal axis, in which we get excess cortisol production. We also see abnormalities with our neurotransmitter systems, specifically with serotonin, norepinephrine, and dopamine. And then we also believe genetics play a strong role in many mental health disorders. Again, the same is true for depression, where if you have a first-degree relative with depression, you're much more likely to develop the disorder yourself. There are many different treatment options for depression, and we're just going to focus on the first-line treatment options, which consist of our selective serotonin reuptake inhibitors, the serotonin norepinephrine reuptake inhibitors, mirtazapine, and bupropion. We no longer use the monoamine oxidase inhibitors or the tricyclic antidepressants as much for depression, just because they have more problematic adverse effect profiles and can be more problematic with drug-drug interactions. Vilazodone and vortioxetine are newer to the market, so you may see patients on these medications, but they're typically not used first line because they're a little more expensive and we don't have as much clinical experience with them. In addition to the medications listed on the previous slide, you may also see patients taking some of the medications on this slide for treatment of depression. We have several complementary and alternative treatments, meaning that patients may either take them along with an antidepressant or in place of a traditional antidepressant, as well as several prescription augmentation strategies, meaning that these medications may be added to a traditional antidepressant to help boost the response or try to help the patient achieve remission. The selective serotonin reuptake inhibitors are referred to as SSRIs, and there are several available on the market. Of the medications listed on the slide, the one that we really don't use for depression much anymore is fluvoxamine, and that is because it is involved in many drug-drug interactions. We still use it for anxiety, but we just have so many other treatment options for depression that we don't see it used as much for that indication. One tricky thing is that all medications have two names, and so listed in parentheses is the brand name of the medication, and sometimes patients, physicians, and nurses will tend to use the brand name, while pharmacists tend to use the generic name, which is the first name listed on the slide. The serotonin norepinephrine reuptake inhibitors are often referred to as the SNRIs, and we also have several of those available on the market. Desvenlafaxine and levomilnacipran are newer agents, so they're still brand name only, meaning that you cannot get them in a generic formulation, so they typically are more expensive for patients. Desvenlafaxine is also the active metabolite of venlafaxine, so those medications are quite similar. Finally, we have our miscellaneous first-line agents, which are bupropion and mirtazapine. One interesting thing to note about bupropion is that it's marketed under the brand name of Wellbutrin for depression and under the brand name of Zyban for smoking cessation. So that brings up an important point about our medications. It's always important to ask patients why they're taking a certain medication. We shouldn't just assume it's for depression. Many of these medications have several different indications, meaning that they can be used to treat different disease states. And then several of them are also used off-label, meaning that they may not have an FDA-approved indication, but providers may use them to treat various disease states. So you'll see antidepressants used to treat things like anxiety, different pain syndromes, as well as something like smoking cessation. The mechanisms of action of these medications can be quite complex, so we will just discuss the basic mechanism of action. And with the selective serotonin reuptake inhibitors, it's kind of nice because their name essentially tells you what they do. They inhibit the reuptake of serotonin from the synapse, which should help boost mood. We're essentially leaving serotonin in a space where the brain can better utilize it. The name of the serotonin norepinephrine reuptake inhibitors also imply their mechanism and that they inhibit the reuptake of serotonin and norepinephrine. So now we'll have more serotonin and norepinephrine in the synapse. They can do this to varying degrees. So for example, venlafaxine tends to inhibit serotonin reuptake at low doses and norepinephrine reuptake at higher doses. Bupropion inhibits the reuptake of norepinephrine and dopamine. So this one's a little bit different in that it's not working on serotonin, which is kind of nice because sometimes we can add it to our SSRIs or SNRIs to try to get an increase in response. It wouldn't really make sense to have patients on 2 SSRIs or 2 SNRIs because their mechanisms are the same or very similar. And then finally, mirtazapine is a central alpha-2 receptor antagonist. And what this does is it causes serotonin and norepinephrine to be released into the synapse. So instead of inhibiting reuptake, these are actually causing release of more serotonin and more norepinephrine. Our antidepressant medications have what we call delayed onset, meaning that patients will not recognize full benefit of the medication for about 4 to 6 weeks or maybe even 8 weeks after they've started it. And any time a dose is increased, it will again take anywhere from that 4 to 8 weeks to notice the full benefit of that dose adjustment. That being said, within the first week, patients should begin to notice some improvements in sleep and appetite. Within 1 to 3 weeks, they should start to notice that their thinking and movements will normalize and they'll have increased activity and improved memory. But we won't see relief of depressed mood or thoughts of suicide subsiding until later into treatment. So this can be quite frustrating for patients because they will unfortunately experience side effects immediately. And as you can imagine, you may not want to continue taking a medication if you're experiencing side effects but aren't really noticing the benefit. So this is an important counseling point for patients. If they've recently started one of these medications and they're saying that it's not working well, you may need to remind them that it can take several weeks to notice the full benefit from these medications. Compared to some of our older antidepressants, these medications are fairly tolerable, but that being said, they're still associated with several adverse effects, and I'm just going to focus on the ones that are listed as more common adverse effects. We actually use our first-line antidepressants to treat anxiety disorders, but it's important to note that they can initially worsen anxiety and agitation. So that's really an important counseling point for patients, letting them know that when they first start the medication or when doses are increased, they may feel more anxious and jittery for the first few days, and then this typically gets better. They may also experience quite a few gastrointestinal side effects, which can be things like nausea, vomiting, and diarrhea. And again, patients tend to usually develop tolerance to this and it gets better, but it's just trying to get them through that period where they're not feeling well. They can also cause sexual side effects, and these can be pretty problematic, so I always try to warn patients about this when they're starting the medication and then ask them about it at follow-up. And then this can be for both men and women. It can do things like cause decreased libido, anorgasmia, and for men it can cause issues with impotence. Some of the medications can cause insomnia, while others can make patients more sleepy, and then some have potential to cause weight gain. One thing to note is that these medications are relatively safe in overdose. So if a patient takes an overdose of the medication, it may not be as life-threatening as it is with some of the older antidepressants. Other than bupropion, these medications work to increase serotonin in the synapse. And sometimes when we get too much serotonin, patients are at risk for developing something called serotonin syndrome, which is characterized as excessive central nervous system serotonergic activity. This typically occurs when patients are taking multiple medications that can increase serotonin in the synapse, but it can occur with one agent alone. So this is an important counseling point whenever we start patients on one of these antidepressants. The difficult part is that serotonin syndrome can be difficult to recognize because the symptoms can start out fairly nonspecific. They can almost look like flu-like symptoms where you can see patients may complain of things like abdominal pain, diarrhea, fever, feeling lethargic, but it can progress to more severe symptoms like mental status changes, renal failure, cardiovascular shock, and ultimately death, which is what we are trying to prevent. So it is important, if you have a patient that's complaining of any of these symptoms, to recommend that they go into either the emergency room or their physician for more immediate evaluation, just to make sure that they don't develop serotonin syndrome. Antidepressants differ in their potential to cause the various adverse effects that we discussed. So some of them are more likely to cause certain side effects than others. For example, bupropion and fluoxetine are more activating and are more likely to cause insomnia than some of our other medications. And we can kind of use this to help guide which treatments to start a patient on if we still have lots of options available to us. So if we have a patient that's already struggling with insomnia, bupropion and fluoxetine may not be our first choice. Paroxetine is associated with anticholinergic side effects, which are kind of drying side effects. They can do things like cause dry mouth, difficulty urinating, constipation, dry eyes. So this medication is typically not best for elderly patients who are already more sensitive to that type of side effect. And then on the opposite end of the spectrum, sertraline is typically associated with more diarrhea. The SNRIs and venlafaxine in particular can cause elevated blood pressure. So if a patient already has a diagnosis of hypertension, we'll just have to monitor more closely. And then patients on citalopram and escitalopram may require electrocardiogram monitoring because these medications can prolong the QT interval, which can lead to arrhythmia. Mirtazapine and paroxetine are typically more sedating, so those are usually dosed at bedtime. And then bupropion has the potential to lower the seizure threshold, so this is not a good medication to use in patients with a history of seizures. And finally, of the first-line medications, mirtazapine and paroxetine are more likely to cause weight gain. If you ever have a patient who is unhappy with their antidepressant, they tell you that they just don't want to take it anymore and they're thinking about stopping it, it's important to tell them to talk to their physician first because these medications should not be abruptly discontinued. They can cause a discontinuation syndrome in which patients will experience a withdrawal if they're abruptly stopped. This is not life-threatening, but it can be uncomfortable and can take about 1 to 2 weeks for the symptoms to go away. It's most common with paroxetine and venlafaxine and least common with fluoxetine. And once again, patients may kind of complain of flu-like symptoms, things like body aches, diarrhea, and fatigue. They can also feel more anxious and irritable during this time. And then I have paresthesias listed, which is interesting, where patients can kind of feel like a tingling or a burning or pricking of the skin, but they'll also describe these electric shock sensations where it feels like they're being shocked by electricity, and they'll specifically even say that their brain feels like it's being zapped. And so this is part of that withdrawal process and why it's important that patients slowly taper the medication before stopping it. There are some special considerations for our elderly patient population, and this patient population is disproportionately likely to die by suicide, and our older white men are especially at increased risk for completion of suicide. So it's important to assess for risk when we have patients on these types of medications, and if a patient is ever expressing any vague suicidal thoughts, it's important to refer them appropriately for further evaluation. They may also present with more physical complaints, and this can be a wide variety of things like dizziness, joint pain, constipation, palpitations, but just recognize that they may not present with traditional symptoms of depression. They also tend to be more sensitive to side effects of the medication. So I mentioned that the drying side effects of paroxetine can be more problematic for an elderly patient population. Patients in this group can also be more likely to experience SIADH, which is syndrome of inappropriate antidiuretic hormone, as well as some movement disorders. We also have to take into consideration their renal and hepatic function. Most of these medications are either cleared by the liver or the kidneys, so they may need reduced dosing if they have issues with either of those organ systems. The elderly are also likely to be on more medications, so we have to be much more careful with drug-drug interactions just because there's higher potential for interactions with their larger medication profiles. And finally, the dose of the antidepressants may need to be titrated more slowly just because the patients do tend to be a little bit more sensitive to the medications. Unfortunately, we don't have a lot of data in our pediatric patient population, and this is true for most of our mental health disorders, in that we don't really conduct a lot of studies in our pediatric patients. So a lot of what we do is extrapolated from data with adults. Children may present more with irritable rather than traditional depressed mood, so just recognize that it can also present a little bit different in this patient population. Fluoxetine and escitalopram are the only antidepressants that have an FDA-approved indication in this patient population, but we do use all of our first-line treatments and use them off-label, and we have quite a bit of experience doing this. There is a black box warning for using the antidepressants in this patient group, and it specifically states there's an increased risk of suicidal thinking and behavior in children, adolescents, and young adults taking antidepressants for depression and other psychiatric disorders. And even though this black box warning is specific to this patient population, I counsel or warn all my patients about that and tell them to monitor for increased suicidal thoughts. And it's just most problematic in our teenage and young 20-year-old patient population. And the thought is that when they start the antidepressant, it gives them an initial boost of energy, which allows them to act on suicidal thoughts before the depression is fully treated. So it is important to have this discussion with the patient and, if appropriate, their parent, just so that we make sure that appropriate monitoring is taking place. After this warning came out, we saw a decrease in prescribing of antidepressants to pediatric patients, but then we actually saw an increase in suicide attempts, and that is because patients were not being adequately treated. So kind of the takeaway from this is that we never want to give a medication to a patient if we don't think they need it. Perhaps there's some non-pharmacologic things we could try first, but if a patient truly needs treatment with an antidepressant, we do not want to withhold that treatment because that can also increase risk for suicide. There may be several different opportunities for patient education with these medications, and that your patients may come in complaining of adverse effects with these medications, with some of the things like nausea, vomiting, and diarrhea, and that initial increase in anxiety. You may be able to just help them get through those first few days and give them things to help manage those symptoms, like taking the medication with food or perhaps at bedtime. Otherwise referring them to their provider for further management of adverse effects. It's important to tell patients to avoid alcohol while taking these medications, just because the alcohol does not allow them to work as well, and alcohol itself is a depressant. Letting patients know that if they're not immediately noticing benefit from the medication, that this is a normal aspect to these types of medications, that they may not notice full benefit for several weeks, so just have patience and try to stick with the medication. If they don't like the medication, tell them to talk to their provider and not to abruptly discontinue it because they can experience those withdrawal symptoms. And then there is potential for drug-drug interactions, so always let patients know that they should talk to their pharmacist or physician before starting new medications. Also, watching for those signs and symptoms of serotonin syndrome and referring a patient for further evaluation if necessary. And finally, continued monitoring of suicidal thinking and making sure to refer patients if they are expressing those thoughts. We're now going to move on and discuss the treatment of anxiety disorders. Similar to depression, we do not know the exact cause of our anxiety disorders, but there are several proposed theories, and pretty much all of them have to do with our neurotransmitter systems. With the noradrenergic model, we know that the autonomic nervous system of patients who have anxiety disorders is hyperactive and tends to overreact to various stimuli. Our locus coeruleus acts as an alarm center in the brain, and this activates norepinephrine release and stimulates the nervous system. GABA is our major inhibitory neurotransmitter in the brain, and there's thought that in patients with anxiety disorders, there's decreased expression of GABA, and so we're not getting the type of inhibitory feedback that patients without anxiety disorders may receive. And then finally, there's a serotonin model, and the thought is that there's decreased levels of serotonin, which can lead to imbalance of other neurotransmitters like norepinephrine. The norepinephrine and serotonin systems are closely linked, so greater serotonin activity in the locus coeruleus reduces norepinephrine activity, and this is what is essentially impaired in patients with anxiety disorders. There are several different types of anxiety disorders, which you should have already been exposed to, so I won't spend time defining and differentiating these disorders. One thing I do want to note is that post-traumatic stress disorder and obsessive compulsive disorder are no longer characterized as anxiety disorders in DSM-5. However, I'll continue to kind of lump them in with the other three anxiety disorders we'll discuss just because treatments are very similar. The SSRIs and some of the SNRIs are our first line treatments for anxiety disorders, and I'm not going to spend time discussing them in this section because we already covered them in the depression section of the lecture. The benzodiazepines and buspirone can be used first or second line for some of the anxiety disorders, so I'll spend my time discussing those agents. We also have several alternative agents that you may see used in the treatment of anxiety disorders. We don't have time to discuss all of them, but I just want you to recognize that there are many different treatment options for anxiety disorders. Listed here are the benzodiazepines that have FDA approved indications for treatment of anxiety disorders. We also have several benzodiazepines that have FDA approved indications for sleep disorders or insomnia. So I do not have those listed here, but you should know that these medications are often used off-label. All of them possess anxiolytic properties, so even if it has an indication for sleep, you may see it used for treatment of anxiety. The benzodiazepines are primarily used to treat generalized anxiety disorder, panic disorder, and social anxiety disorder. We do not usually use them for PTSD or OCD, and we actually have data demonstrating that the benzodiazepines can be harmful in patients with a history of PTSD, so we'll typically try to avoid using them in that patient population. They are our most effective medications in regard to rapidly relieving anxiety symptoms. So you recall from our discussion on the antidepressants that the SSRIs and SNRIs can take several weeks to start working. And for some patients, that's just too long to continually feel those anxious symptoms. And so a benzodiazepine can be started to help rapidly relieve those symptoms, and then is generally continued for about 2 to 4 weeks until the antidepressant starts to take better effect. That being said, you will see some patients on benzodiazepines long term for treatment of anxiety, and although this is not ideal, this does happen in a clinical setting where providers may deem it appropriate to continue long-term treatment. Otherwise, we typically try to reserve benzodiazepines for what we term bridge therapy, where we're just using them as a bridge until the SSRI or SNRI takes effect. They are more effective for treating the autonomic symptoms of anxiety rather than the psychiatric symptoms. So they don't do a great job of relieving things like apprehension or worry. They also do not work for depression. There is potential for abuse and physical dependence with these medications, so we typically will avoid using them in patients with a history of substance use disorder. So if you have patients abusing things like alcohol, marijuana, opioids, any other type of substance use disorder, benzodiazepines may not be an ideal treatment option. The mechanism of the benzodiazepines is fairly straightforward. They work on our GABA receptors, and they essentially enhance the inhibitory effects of GABA. The benzodiazepines work on the same receptor that alcohol works on, so the side effects of these medications can look very similar to someone who's intoxicated on alcohol, where we'll see a lot of CNS depressive side effects. With ataxia, this is typically lack of coordination of muscle movements, and then psychomotor impairment can increase risk of falls, cause confusion, or things like memory problems. Sedation is the most common side effect associated with the benzodiazepines, and due to these side effects, it's important that patients not drive or operate heavy machinery if they are experiencing these side effects. They can also experience anterograde amnesia, which is difficulty remembering events that occur after the drug was ingested. Due to the potential for abuse and dependence, these are Schedule IV controlled substances, so there are more regulations on how they're prescribed and dispensed. And it is important to tell patients to avoid alcohol while taking benzodiazepines. The side effects from alcohol and the benzodiazepines can be additive and potentially fatal if a patient develops respiratory depression. And there is overdose potential with this medication due to that respiratory depressive side effect. So if a patient takes too much, they could quit breathing. It's also important to counsel patients to not abruptly discontinue benzodiazepines. Unlike the antidepressants, benzodiazepine withdrawal can be life-threatening. As you can see, patients can develop things like seizures and could potentially die as a result of this. So these medications do need to be tapered over several weeks to months to help avoid those withdrawal symptoms. Due to their adverse effect profiles, we typically try to avoid benzodiazepine use in our elderly patient population. You will see elderly patients on these medications, but ideally we try to minimize or avoid their use due to risk of falls, confusion, and sedation. If we're going to use a benzodiazepine, lorazepam, oxazepam, and temazepam are preferred agents just because of the way they're metabolized and they're less likely than some of the others to accumulate. Temazepam is FDA approved for treatment of sleep disorders. These medications can also cause paradoxical disinhibition in some patients, and where it can actually increase their anxiety, irritability, and agitation. So we just have to be careful with using them in this patient group. And if we do use a benzodiazepine, we typically will use lower doses and titrate them much more slowly. There are several potential advantages and disadvantages to using benzodiazepines for treatment of anxiety. Many of the benzodiazepines come in multiple different dosage forms, which can be nice and convenient for patients. They're not likely to worsen anxiety like some of our antidepressants do, and they have a very rapid onset, so they can more quickly relieve anxiety symptoms. However, these medications are dangerous if combined with alcohol. They're not ideal for our elderly patient population or our pediatric patient population. They're not recommended for use in PTSD or OCD. There is potential for abuse and dependence as well as overdose. And then they have a pretty problematic adverse effect profile and cause withdrawal symptoms if abruptly discontinued. We are just going to briefly discuss buspirone, which is typically just used for treatment of generalized anxiety disorder. Its mechanism of action is not fully understood, but it's thought to be a serotonin 1A partial agonist, meaning that it acts on the serotonin 1A receptor. It's fairly well tolerated medication in that the most common side effects are things like nausea, headache, dizziness, and an initial nervousness like we'll see with our antidepressants. In terms of advantages to using this medication, it's pretty safe, and so it has a nice safety profile compared to the benzodiazepines. There's really minimal or no abuse or dependence potential. It's not sedating, and it's well tolerated. Unfortunately, it does have a longer onset like our antidepressants, and so it may not take effect for 2 weeks or longer, which can be problematic for some patients. It is dosed 2 to 3 times per day, so this can be problematic for patients who have difficulty remembering to take their medications. It's not effective for all anxiety disorders and is pretty much just used for generalized anxiety disorder. It can initially increase anxiety, and it takes a few days for patients to become tolerant to that. And then there is mixed evidence for use. We don't have a lot of strong data showing that it's really effective for anxiety disorders. We're once again going to switch gears and discuss the treatment of bipolar disorder. We also do not know the exact cause of bipolar disorder, but there are multiple theories, and these theories look very similar to those that we saw for depression. Once again, genetics appears to play a fairly strong role in that if you have a first-degree relative with a history of bipolar disorder, you have a much better chance for developing the disorder yourself. The treatment of bipolar disorder can be a little confusing because we have some medications that work better for treatment of mania and some that work better for treatment of depression. Those medications listed in bold are generally considered a first-line treatment option. So lithium is considered a first-line treatment option for both mania and depression, while divalproex sodium is considered a first-line treatment for mania, and lamotrigine is considered a first-line treatment for depression. We can also use carbamazepine and oxcarbazepine for mania, and our antipsychotics are actually used for treatment of mania and depression as well, and we'll discuss them more in the schizophrenia portion of the lecture. Lithium is considered a gold standard treatment for bipolar disorder because it's a very effective medication and very well studied. It's also been around for a long time, so we have a lot of clinical experience with it. However, there are several important considerations when a patient is on lithium, and one is that we have to get blood levels of the lithium because if the level gets too high, the patient can develop toxicity. And there are several different things that can alter lithium levels, and there's really nothing on this slide that you need to memorize, but what I want you to take away from this is that there are several drugs and different conditions that can alter a lithium level. So it's really important to tell your patients to talk to their physician or pharmacist before starting new medications. It can even be over-the-counter medications. Things like ibuprofen and naproxen can increase lithium levels. We also want to make sure that patients are drinking consistent amounts of water. If they become dehydrated or if they're drinking too much water, this can affect their lithium level. We also want to make sure that if they're ill, so if you have a patient who's vomiting or has diarrhea, that you recommend that they see their provider because this can also impact their lithium level. Lithium is associated with many adverse effects, and once again, I don't think there's anything specific on this slide that you need to memorize, but what you should take away is that lithium really impacts almost every organ system and makes it very difficult for patients to tolerate. As you can imagine, many patients have difficulty adhering to lithium therapy because of these side effects, and so they may be tempted to quit taking it. Some of the side effects listed in bold are side effects that are more likely to occur when the patient first starts the medication or when a dose is increased, but then they tend to go away. Those listed in normal font tend to be more long-term side effects associated with the medication. Some things like polydipsia and polyuria, those can be initial and long-term side effects. There are several different things we can try if a patient develops some of these adverse effects, and our ultimate goal is to try to keep them on lithium therapy. If a patient's complaining to you about having nausea, vomiting, or diarrhea, you could try recommending that they take the medication with food. If they're complaining of weight gain, which can be fairly problematic with lithium, you can counsel them on proper diet and exercise. And in general, if they're complaining of side effects, it's just great to recommend that they follow up with their provider because, as you can see, there are many different things we can try to help counteract these adverse effects. As previously mentioned, lithium can cause toxicity if the levels get too high. And on this slide, I have different columns with various lithium levels and the symptoms that patients may present with. But it's important to remember that we always treat the patient and not the level. Sometimes patients will present with symptoms of toxicity at much lower lithium levels. So this is meant to just be a guide. One thing that's kind of tricky is that some of the symptoms of toxicity are also the same side effects that we'll just see naturally with lithium. So I mentioned lithium can just cause nausea, vomiting, and diarrhea. So kind of the big thing here is that if a patient comes to you and they've been tolerating the medication pretty well, but now all of a sudden, without any change in dose, they're nauseous or vomiting, or they say that their tremor's gotten much worse, that's where we want to recommend that they see their provider and get a level checked, because for some reason they may be toxic. As the level gets higher and higher, the symptoms become more severe, where patients may have difficulty walking or with coordination. They may be confused and have difficulty speaking. And this can ultimately progress to things like seizures, coma, and death. So it's very important to help kind of monitor patients on lithium for these signs and symptoms. There are things we can do if a patient develops toxicity on lithium. Most patients will either receive whole bowel irrigation, or if the level is high enough or the toxicity severe enough, they may require hemodialysis. Some patients will also require intubation to help protect the oral airway. So this can be pretty severe, and the treatment is fairly intensive. Our elderly patient population may require lower maintenance doses of lithium, and that's because as we age, our total body water decreases, so there's less water for the lithium to distribute into. As we age, our kidney function can also decline, so we need to monitor renal function closely and make sure that the lithium is not accumulating. Once again, with our pediatric patient population, there's really sparse or weak evidence for use of lithium. That being said, it is the only mood stabilizer that has an FDA-approved indication in children. There are some dosing recommendations for children who are greater than 12 years old, and really we'll only consider lithium when the parents are highly reliable, because we need someone that's reliable that can get the children to the appointments for the blood monitoring. We also need them to help us monitor for those symptoms of lithium toxicity. Divalproex sodium was originally developed for patients with seizure disorders, but we also use it as a mood stabilizer for patients with bipolar disorder. As previously mentioned, it tends to be more effective for helping treat and prevent the manic symptoms of bipolar disorder. This medication is associated with several adverse effects, and so it can be very difficult to tolerate, just like lithium. Some of these side effects are considered more concentration dependent, meaning that you're more likely to see them as once the medication started and as doses are increased. Some of them are idiosyncratic, meaning that we don't really know why they occur. And then some are more chronic, meaning that they're more likely to happen with longer term therapy. Tremor is kind of a hallmark side effect associated with this medication, where you'll see patients with hand tremors. We'll also often have patients complain of things like nausea, vomiting, and diarrhea with this medication as well. Another fairly common side effect that patients don't enjoy is the weight gain. It can also cause alopecia, which is hair loss. So for some of these side effects, they're noticeable, and some of these cosmetic things can be very difficult for patients to tolerate. Carbamazepine was also originally developed for patients with seizure disorders, but once again, we use it as a mood stabilizer. This is more of a second-line treatment option for patients who have mania, or we were trying to prevent mania. A lot of the side effects with this medication are kind of central nervous system type side effects, where we can see double vision, dizziness, drowsiness, unsteadiness. It also has a black box warning for a rash, which we'll talk about more in just a moment. And then we can also see blood dyscrasias, meaning like anemia or severe neutropenia, where we're monitoring their complete blood cell count. Finally, we have lamotrigine, which was also originally developed as an anticonvulsant. Unlike divalproex and carbamazepine, lamotrigine tends to be more effective for treating and preventing the depression associated with bipolar disorder. This medication also has a black box warning for rash, and also has a lot of central nervous system side effects. So once again, the double vision, difficulty with coordination, dizziness. But compared to divalproex, carbamazepine, and lithium, this medication is typically better tolerated. I want to spend a little bit of time discussing rash associated with medications. Any medication has the potential to cause rash if the patient is allergic to it. So really our biggest signs of an allergic reaction to a medication is either the patient developing a rash or their throat swelling. And so if a patient tells you that they started a new medication and they develop a rash, you'd want to refer them to their provider or tell them to go to the pharmacy to let them know, so that that rash can be evaluated. However, with carbamazepine, divalproex, and lamotrigine, this rash can be very severe, and so we want to take it even more serious than a typical allergic drug rash. The rash can present in three different forms. It can be anticonvulsant hypersensitivity syndrome, Stevens-Johnson syndrome, or toxic epidermal necrolysis. And the anticonvulsant hypersensitivity syndrome is the least severe presentation, with toxic epidermal necrolysis being the most severe presentation. You can Google image Stevens-Johnson syndrome and toxic epidermal necrolysis just to see some pictures of how severe this can be. But this rash can be so severe that patients can end up on a burn unit, and sometimes they'll even need skin grafts that may affect their ophthalmic membranes, their mucous membranes in their mouth. So it's very uncomfortable and can be very severe. So this is something we want to take serious if a patient develops a rash on one of these medications, and we want to more urgently get them evaluated in either an emergency room or immediately by their physician. The final disease state we're going to discuss is schizophrenia. By now, this slide should look fairly familiar in that we do not know the exact cause of schizophrenia, but there are multiple different theories, and it's likely multifactorial. Once again, genetics appear to play a pretty strong role. There's also some interesting neurodevelopmental models with schizophrenia. There are some studies showing that women who develop upper respiratory tract infections during the second trimester of pregnancy are then at increased risk for having children who later develop schizophrenia. We also see some brain structure abnormalities, and you'll see some pictures of that in just a moment. There appears to be some gray matter loss in patients with schizophrenia. Patients with schizophrenia also appear to have Compared to some of our other mental health disorders, we have a fairly good understanding of the neurotransmitter abnormalities that are occurring in schizophrenia. And we know patients with schizophrenia have abnormal dopamine concentrations, in which dopamine levels may be too low in some areas of the brain and too high in other areas. And we're primarily focused on those high dopamine levels because we know that excess dopamine causes symptoms of psychosis. There are 4 dopaminergic tracts in the brain, and those are the nigrostriatal, the mesolimbic, the mesocortical, and the tuberoinfundibular. In the middle column of the table, I have what normally occurs in those tracts with normal dopamine concentrations. On the far right side, there's a column that shows what happens if you give a dopamine antagonist or a dopamine blocker. So as you can imagine, if these patients have high dopamine levels and that is causing psychosis, many of our medications are going to work to block dopamine. So if we block dopamine in the mesolimbic and perhaps the mesocortical tracts, this can help relieve psychosis. However, blocking dopamine in the nigrostriatal tract can lead to movement disorders, and blocking it in the tuberoinfundibular tract can lead to increased prolactin, which can also cause side effects. There's some thought that there's too much dopamine in the area of the caudate nucleus, which leads to some of the positive symptoms of schizophrenia, so things like the hallucinations and delusions, while there may be dopamine receptor hypofunction in the frontotemporal regions of the brain, which can then contribute to the negative symptoms, which would be things like flat affect and lack of motivation. In regard to treatment, we have our first generation antipsychotics and second generation antipsychotics, which is primarily the preferred terminology for these classes of medications. You may hear people refer to first generation antipsychotics as either traditional or conventional antipsychotics, typical antipsychotics, or neuroleptics. You may also hear people refer to the second generation antipsychotics as atypical antipsychotics. Listed here are the first generation antipsychotics available on the market, and you won't really see these used much anymore for reasons we will discuss. Of the agents listed, the one that you'd most likely see would be haloperidol or Haldol. The first generation antipsychotics work to block dopamine, so they are dopamine receptor antagonists, and they really have a high affinity for the dopamine 2 receptors. This helps reduce the positive symptoms of psychosis, but is also responsible for some side effects Dopamine highly regulates movement, so when we're blocking too much dopamine, we can get movement disorders. They also hit many other receptors like our muscarinic, histamine, and alpha 1 receptors, so they're kind of messy drugs, and that we'll see a lot of different side effects with these medications. Based on that messy mechanism of action, the first generation antipsychotics are associated with many different adverse effects. And similar to our discussion on lithium, these medications affect several different organ systems in the body and are very difficult for patients to tolerate or kind of maintain treatment with this group of medications. We won't go through all of these side effects in depth. Really, the one we're going to focus on is the extrapyramidal symptoms, which are also known as the movement disorders. There are several different forms of extrapyramidal symptoms or movement disorders, and the first one that we'll discuss is dystonia, which is abnormal muscle tonicity or sustained muscle contractions. And this can be quite painful for patients, and it can present in many different ways. Torticollis is a twisting of the neck in which the top of the head points in one direction and the chin in another. Laryngospasm is spasming or contraction of the larynx. Oculogyric crisis is when the eyes become stuck in a fixed position, usually upward. Retrocollis is when the head is thrown backwards. Trismus is when patients are unable to completely open their mouths. And then glossospasm is a spasmodic contraction of the tongue. Blepharospasm is a forceful contraction of the eyelid. Usually patients' eyes are forced shut. And then epistotonus is when the back is arched with the head thrown backwards. And I will show you a few pictures of some of these things. I do have treatments listed there. We're not going to go through the treatments for the different movement disorders. It's there for your reference. But this is something that we'll try to treat immediately just because it is so distressing and potentially painful for patients. Here are some pictures highlighting some of the types of dystonia we just discussed. You can see with torticollis, that twisting of the neck where the chin is pointing in one direction and the top of the head in another. Retrocollis where the head is drawn backwards, and then epistotonus, which is that arching of the back with the head thrown backward. So you can see that this would be pretty uncomfortable and a side effect that patients really don't enjoy because others can see that there's visibly something wrong with them. These medications can also cause pseudoparkinsonism, which resembles Parkinson's disease. Parkinson's disease is caused by too little dopamine. So if our medications are working to block dopamine, it makes sense that patients can develop side effects that resemble Parkinson's disease. So we'll see things like akinesia, which is absence of voluntary movement, bradykinesia, which is slowness of movement, that stooped posture and shuffling gait. The image on the slide is showing a patient being tested for cogwheel rigidity. If we try to move the patient's elbow at that joint, we should be able to move it with a fluid motion, but patients with either pseudoparkinsonism or Parkinson's disease may have cogwheel rigidity, where it's very stiff and it's almost like the joint is ticking like a cogwheel. Once again, the treatments are listed for your reference. The next type of movement disorder is akathisia, which is an inner restlessness or an inability to sit still. So these are patients on an inpatient psychiatric unit who are constantly pacing the hallways, or if you're trying to interview them and they're sitting in a chair, they may be constantly shifting position or tapping their feet. So these patients will often say that they just feel restless and like they need to get up and move. The final type of movement disorder we will discuss is there are several risk factors for developing tardive dyskinesia, and a couple of the big ones are duration of antipsychotic exposure and increasing age. The incidence is about 5% per year, but can range from 20 to 25% with long-term treatment. And then the prevalence is about 5 to 10% in patients older than 40 years old, but as high as 50 to 80% in the elderly. So this is something we want to constantly evaluate and make sure that the patient actually needs the antipsychotic medication. If we're in doubt as to whether they still need that medication, perhaps we should try to taper and discontinue it. We also want to use the minimum effective dose and not give them higher doses than necessary. We can try using the second generation antipsychotics, which are less associated with these movement disorders. The anticholinergic medications, or medications again that have those drying properties, can actually worsen tardive dyskinesia, so we'll try to discontinue any of those medications from the profile. We can also assess for signs using rating scales. This is typically done by psychiatrists or sometimes psychiatric pharmacists. But one thing to note is that some of these movements can be very subtle. So for the untrained eye, you may not even notice that the patient is experiencing a movement disorder, where some of them are very obvious and can obviously interfere with the patient's activities of daily living. It may interfere with their ability to eat correctly or speak correctly, and that's why it's so important that we're assessing for this type of movement disorder. Unfortunately, tardive dyskinesia may be irreversible, which is ultimately why we try to prevent it. If a patient does develop tardive dyskinesia, we should try to discontinue the antipsychotic if we think the patient can tolerate it. I have listed there that it can cause a withdrawal dyskinesia, meaning that the movements can actually get worse for the first few days to maybe a couple weeks after the medication is withdrawn, but then hopefully over a period of weeks to months, the movements will get better. We don't really have a great treatment for tardive dyskinesia. I have a few treatment options listed there, but none of them have FDA approval and none have a lot of great data supporting their use. Clozapine is a second generation antipsychotic and is less associated with movement disorders. Tetrabenazine is a treatment for Huntington's disease, and so we'll most often see those used. Sometimes providers will try vitamin E because it's a fairly safe medication, but again, there's not really a lot of great data supporting its use. We're now going to move on and talk about the second generation antipsychotics. As previously mentioned, the second generation antipsychotics are often referred to as atypical, and there's really no agreed upon set of characteristics that define an atypical antipsychotic. But in general, we'd like them to also have the ability to block serotonin receptors and to be effective for patients who have treatment resistance, meaning that maybe they've tried and failed a couple of agents. We also want it to be effective for positive and negative symptoms, as well as improved cognitive functioning. Ideally, we'd like it to have low to no extrapyramidal symptoms and no change in serum prolactin. So we have several second generation antipsychotics available on the market, and not all of them meet these characteristics, but in general they do a better job of meeting these criteria than the first generation antipsychotics. Listed here are the second generation antipsychotics. Several of them are newer to the market, and those are the ones that are highlighted in bold, meaning that they're only available as brand name products and there is not yet a generic available on the market. The mechanism of the second generation agents is a little different than that of the first generation antipsychotics because these medications are dopamine and serotonin antagonists, meaning that they can block both dopamine and serotonin receptors, and the different drugs have different affinities for these receptors. They also don't bind as tightly to that dopamine 2 receptor, and they kind of bounce off and on the receptor versus binding tightly and really holding on to it, which helps reduce side effects. They're not as messy as the first generation products either, in that we have less blockade of those muscarinic, histamine, and alpha-1 receptors. The adverse effect slide for the second generation antipsychotics looks very similar to that of the first generation antipsychotics. Depending on the medication, we have essentially the same adverse effect profile, but in general, these medications are less likely to cause these side effects. So we're less likely to see movement disorders, we're less likely to see changes in prolactin. And so in general, they are tolerated better, but there's still potential for those side effects. I do have some listed in bold. We will see more nausea and vomiting with the second generation products because of their action on serotonin. We also see more weight gain issues with blood sugar and cholesterol abnormalities with the second generation products. The medications differ in their potential to cause the metabolic side effects, which again consists of things like weight gain, increased risk for diabetes, and worsening cholesterol. Clozapine and olanzapine are our biggest culprits, meaning that they're most likely to cause those side effects. Risperidone and quetiapine fall in the middle, and then aripiprazole and ziprasidone are considered lower risk. Now, as you can see from the citation on this slide, this data comes from a consensus statement that was released in 2004, so this is quite old. At that time, aripiprazole and ziprasidone were newer to the market, so we didn't have a lot of data with them. At this time, we do know that these medications are considered low risk. This is just another visual representation of the information that was included on the previous slide, showing that clozapine and olanzapine are high risk for metabolic side effects. Risperidone and quetiapine fall more in the intermediate or moderate range, and then ziprasidone and aripiprazole are low risk. I also included some of the agents that are newer and were not included in that 2004 consensus statement. Iloperidone and paliperidone likely fall somewhere between low and moderate risk, and then lurasidone and acenapine also appear to be low risk. Brexpiprazole and cariprazine are newer to the market, and we don't really have a lot of long-term data with them yet. They do appear to be more low risk, so I imagine that's where they'll fall in this profile. There is some very specific monitoring that's recommended to help monitor for these metabolic side effects. At baseline, all patients should have a weight, waist circumference, blood pressure, fasting plasma glucose, and fasting lipid profile obtained. They should have their weight rechecked at 4 and 8 weeks after starting the medication. And then after they've been on the medication for 12 weeks, we'll want to recheck weight, blood pressure, fasting plasma glucose, and a lipid profile. From then on, for every 3 months that the patient is on the antipsychotic, they should have their weight rechecked. Annually, we'll want to recheck their waist circumference, blood pressure, and glucose, and then recheck lipids at least every 5 years or as clinically indicated. For most of our patients, we will recheck their cholesterol on an annual basis. Now, this monitoring is pretty important because oftentimes it gets missed. I think a lot of times psychiatrists assume that the primary care providers are doing it, and primary care providers may think that the psychiatrists are doing it. So if a patient comes to you and they're complaining of increased weight, this is a good time to counsel them on proper diet and exercise, as well as to potentially recommend they follow up with their primary care provider or psychiatrist to have this monitoring performed. I have seen patients gain as much as 80 pounds within just a few months of starting one of these medications. And unfortunately, even if we stop the medication, it doesn't mean that the weight just comes right back off. It can be very difficult for patients to lose this weight. I've also had many patients develop diabetes because of taking these medications, and then ultimately they end up having to take additional medications for things like diabetes and high blood pressure and high cholesterol. We'll typically consider some type of intervention if the patient gains greater than or equal to 5% of their initial body weight after starting the antipsychotic. It's always important to counsel on diet and exercise. I find that a lot of my patients have problematic diets, and so there's usually a lot of room for intervention. We can also potentially switch to a second generation antipsychotic that has a lower risk for causing metabolic side effects. But this may not be an option for all patients, because if the risk of decompensating their mental health outweighs the potential benefits, psychiatrists aren't going to likely try this. We can also medically treat the metabolic side effects, so as mentioned, starting medications for things like diabetes or hypertension, but this is also not ideal because it introduces polypharmacy, and now we're using medications to treat side effects. We can consider appetite suppressants or weight loss drugs, but I often find in my patient population that the risks associated with those types of medications often outweigh the benefits. The antipsychotics are used in our elderly patient population, but we do need to be cautious because they appear to be sensitive to the side effects, and we also have to be careful with declining renal and hepatic function because this may require dose adjustments of the medication. All of our antipsychotics have a black box warning for elderly patients with dementia-related psychosis, and that's because there is an increased risk of death in that patient population. And those deaths appear to primarily be cardiovascular or infectious in nature. So prior to starting an antipsychotic in a patient with dementia-related psychosis, we should try to do as many non-pharmacologic interventions as possible. We need to do a thorough workup to make sure that there's not some underlying medical condition causing the patient's symptoms. Something as simple as a urinary tract infection can cause psychotic symptoms in this patient population. We should also make sure that their environment is as comfortable as possible, meaning that their room is at a good temperature, there's adequate lighting, that we remove anything from the room that may be distracting or confusing to the patient. Sometimes something as simple as a coat rack can look like a person to a patient with dementia. If necessary, we can start an antipsychotic in this group, and we do use them, but we want to maintain the lowest effective dose and continually reassess the need for the antipsychotic. Just because it's started, it doesn't mean that they have to be on it forever. If possible, we should try to taper the dose and discontinue it. Onset of schizophrenia in childhood is rare, but there are children who receive this diagnosis and are treated with antipsychotics. There are several second-generation antipsychotics approved for the teenage patient population, and then we may need to use them off-label if children are younger. Risperidone is actually quite effective for the behavioral problems and aggression associated with schizophrenia in our pediatric patients, but our pediatric patients are also more sensitive to metabolic side effects and the extrapyramidal symptoms, so you may actually see providers start with one of those agents that's more low risk on the metabolic side effect spectrum. As usual, there's very limited or sparse study data in this group, so a lot of what we do is extrapolated from adults. And then the picture on this slide really doesn't have anything to do with pediatrics, but I think it's interesting. It's paintings of a cat over a period of time in which an artist developed schizophrenia. So the picture in the upper left is his view of the cat early in his diagnosis, and then the picture at the bottom right is as the illness progressed and became more severe. So I always think this is interesting and shows how the patient's view may be distorted by schizophrenia, and you can imagine that this could be quite scary for patients. That concludes our presentation, and I know there was a lot of information in this presentation and some of it was complex, so please feel free to email me at the email address listed on this slide if you have any questions. Otherwise, please pass your questions along to your course coordinator and she'll gather them all and pass them along to me. Thank you for your time.